Well, let's go about as far away from the neck as possible, and let's talk about feet. So we're going to talk about the ground reaction forces. Really, it's this vertical line that comes up through the ankle, back of the knee, if we follow this line. And it influences the hip, actually influences a lot of things. And really, I'm going to talk about one of my favorite subjects, which is not the same for most people. It's the foot. I love sort of this animation when it shows the foot collapsing under this vertical load. This is an amazing structure. 33 joints, 26 bones, hundreds of ligaments. But because it's so amazing, it has a lot of opportunities for failure. And almost so amazing that the first Honda robot that came out had those ski boot feet and it kept falling over because the adaptability of the foot lets us walk on varied surfaces. This is tremendous, and we can't fake this. Like, you can't do it. They're making robots on tracks because they just decided they can't figure out how to make one that can adapt the way that the human foot is. So ground reaction forces are 2 to 3 times your body weight when you're running efficiently, up to 15 times your body weight when you're not. So young Gary Edwards is parking his Suburban on your foot every time you take a step at 1,700 pounds. That's a lot of load. And when we talk about the load, we're really talking about the talus right here. Oop, wrong, we went ahead. Talus, where that mouse is. The talus is the bone that connects to the tibia. And I enjoyed Dr. Pitts's last slide on that tibial fracture because I looked down and I could see the head of the talus. This is about the size of a golf ball, a little bit bigger, and it's running at 900 pounds when you're running force through that joint every single time. Now, the talus is great because it's supposed to allow us to articulate. Dorsiflex is what we're looking for. Normal running has about 15 degrees of dorsiflexion. Most of us aren't normal on how much dorsiflexion we actually have, which means we're sort of transmitting that force through this navicular and cuneiform. Their job is not really to dorsiflex. Their job is to adapt to varied surfaces on the ground. This is great, right? And this is really how we all feel like we're running. And those of you who've run in a race and they've taken a picture of you with your tongue hanging out, your hair all a mess, you're like, I think this is great. I like to use this as this is what my foot looks like when I'm running versus what I think it looks like when I'm running. In the physical therapy world, there's a course, and it's actually called When the Foot Hits the Ground, Everything Changes. We have another name for it, and maybe this video will explain it. This is a 25-year-old marathon runner. He weighs about 200 pounds. He's fairly efficient, so 200 times 3 every step on his talus and every step on his midfoot. His heel cords are short. He has about 0 degrees worth of dorsiflexion. Let's just watch him run just for a hot second. Don't know how long a hot second is, but we'll see. Look at that midfoot just collapse down. And that's what happens. It just blows up. He actually made it through the race with a lot of foot pain, but they always say running a marathon is really about the struggle. It's not about the fitness. It's like, can you just tolerate the pain and make it work? Triathletes are the same way. It's managing injuries. This is a very busy slide. I just want to point you to the navicular because that's the one I want to talk about. This is the keystone of an arch. If you know anything about the keystone, it's that wedge-shaped kind of stone in the top, and it holds everything up. With the keystone in, the arch doesn't fall. We have a muscle that is used. I love this slide, mostly because I made it. You know what? Just wait. It's really cool. The posterior tib, its job is to hold the navicular in place. Its job is to kind of form the top of that arch. When the navicular's in place, the arch stays put, and you can drive Gary's Suburban on your foot, and it will be fine. But when the navicular slides down, the arch collapses. Everything goes to pieces, right? And the posterior tib, which is indicated here, the posterior tib is not ideally positioned to lift the navicular. It's just to hold it in place to give rigidity to, rigidity to the foot, right? And allow us to progress over rigid forefoot without our arch completely collapsing. Now, if it completely collapses 10,000 steps a mile, we have problems, right? If the posterior tib is asked to do a very simple job, and its simple job is to just hold the navicular in place. Sort of like, we'll say Carolyn Strong. Carolyn, right, is holding a picture frame up on the wall. Let's just hold this picture right there. Not a lot of effort, but it does take some time. And then somebody throws a safe and tells her to catch it at 10,000 times a mile, right? Eventually, if not properly supported, and adequate range of motion, posterior tib becomes fibrotic, and then it's non-functional. This keeps happening long enough, the midfoot breaks down, and then you got to go see a foot surgeon. Nobody really wants that. And while surgery is great, anytime you're changing the biomechanics of the foot, how the foot hits the ground, life changes for you, right? So here's this whole thing as we talk about the foot coming all the way up, right? So we have a pronated foot. It causes internal tibial rotation. Knee goes valgus. Sometimes we just have young people who have knee pain. Is it the foot? Is it the hip? We don't know, right? Internal femoral rotation, and then the pelvis rotates anterior on that side. What do we think is going to happen to the spine all the way up? Dr. Edwards' sagittal balance has just gone to crap because the anterior pelvic tilt on one side, right? Most people have it on both sides, so that's great. At least they're balanced out. Interesting study in clinical biomechanics. They just wanted to see if they could eliminate this knee torsion. This was a study on patellofemoral syndrome. They just put, that little white arc under his foot. They just put an anti-pronation orthotic in there, and they were able to reduce this internal tibial rotation and femoral rotation kind of at the same time with the device on a step up. Okay, 15-year-old patient. This is what we came for. We want to talk about patients and how it affects them, right? 15-year-old patient, post-ACL. Nobody in this room did this surgery. Comes to us. She wasn't really getting all the range that she wants. And you look at it and you think, okay, so it's her right knee. We can see it's not completely straight, and maybe it's looking a little bit off. She's got her shoes on. I want to encourage all of the clinicians in this room to start looking at feet. This is what steps on the ground first, and this drives everything. I know we can say that the hip, and there's decent research on both sides, hip strength can correct pronation. Pronation can correct hip strength. It's the hip that's the knee. We never really know. So I said, let's take your shoes off. Let's take a look and see what's going on. Not those shoes. That's a different story. Hang on. So we want to squat just to see what's happening. A little dynamic valgus, that knee's coming in. We're like, okay. But I'm thinking maybe we should get the socks off and just see what's happening here, right? So like, still there, not nothing, nothing's really kind of standing out as I look at it, right? Let's look at it from the back. Holy Batman, what is that right foot doing? So here's our question. Clearly post-op knee surgery. She's 4- out of 5 on her hip strength on that side, absolutely. She's got a quad problem, right? She comes into physical therapy, comes in to see you guys, and you're like, that quad's small, you need to build it, or your glute's too small, right? Are we considering that her ankle has a significant problem here and maybe the reason that she's driving medially? I can strengthen her hip all day long, but if I forget to take her shoes off, if I forget to ask her what's going on, by the way, taking shoes off can sometimes give you this problem in your clinic. If I forget to have them take their shoes off, if I forget to look at the way their foot is contacting the ground, then maybe I can miss something important for a patient. We know that a shoulder problem is also a neck problem unless absolutely ruled out. We know that a hip problem is also a back problem unless absolutely ruled out. And I will tell you that a knee problem is either a hip problem or a foot problem or maybe just a knee problem. But if you're not doing your patients the service of at least checking all of those, then it's time to look a little farther down to the first piece that hits the ground. There's a very complex relationship about how this works. The foot can change everything. This diagram shows just a little bit of that. It's time to get people's shoes off and start looking about how they meet the ground, because our job is to assess the patient from the ground up. Thank you very much.